Welcome once again to Good Samaritan Hospital and the next in our series of community educational lectures. Today I'll be talking about atrial fibrillation, which is appropriate because it's still Heart Month. Atrial fibrillation is probably the most common of the sustained rhythm abnormalities that we treat in the heart. In fact, it is known that patients or population greater than the age of 80, approximately 10 to 15% will develop, either are treated or have been treated for atrial fibrillation. Now, before I talk about fibrillation, I'd like to review a little bit of the basic cardiac anatomy so that we're all on the same page. As most of you know, the heart consists of 4 chambers. The upper chambers are called the atria, lower chambers are called the ventricles. In the beginning of the heartbeat, the atria contract together, synchronized, organized fashion, and push blood into their respective chambers, the ventricles. Shortly thereafter, the ventricles will contract and push blood to the body. The average rate that this happens, the so-called heart rate, is dictated by an area in the right atrium called the sinus node. This is sort of like the captain of the ship, if you will. The sinus node takes its cues from the body as to how fast it will give out an electrical impulse to initiate the process. Of course, things like exercise or stress or infection and fever are things that will be picked up by the sinus node and require or result in a faster heart rate. When the sinus node gives off its impulse, it spreads evenly through these upper 2 chambers, the atria, so that they contract in a synchronous fashion. As I said, they each push blood equally into both ventricles at the same time. Now, this impulse stays in the atrium. It cannot traverse into the ventricles right away. Instead, that electrical impulse gets organized in a second area, a second node in the heart called the AV node or atrioventricular node, where you see that yellow star. It kind of hangs out there for about 200 milliseconds, giving enough time for the atria to do their work, push blood into the heart. And then after that time, the impulse exits the AV node, spreads evenly throughout the cardiac muscle, spreads to right and left ventricles, so the 2 ventricles contract together. The right side of the heart, as you may know, receives blood from the body after it's utilized all the oxygen. So it's sort of called deoxygenated blood. Travels into the right ventricle, then gets pumped to the lungs where it picks up oxygen again. And now this oxygenated blood comes back to the heart, to the left atrium, to the left ventricle, where it is then pumped out to the rest of the body. So what happens when this process gets disrupted? Now, for reasons, and there are many possible reasons, which I will review in a few minutes, over the course of time, later in life, more likely, atrial muscle becomes irritated and starts firing its own little impulses all over the place. Frequent. The sinus node pretty much shuts down because it's not needed. Because the impulses in the atrial muscle are very disorganized, the muscle doesn't contract evenly. It sort of fibrillates or quivers. Now, the depolarization or the electrical impulses from the atrium, the frequency of that is about 300 to 400 impulses per minute, which means that AV node is bombarded between 300 and 400 times every minute. Now, the heart cannot sustain life beating at that kind of a heart rate. But luckily, the AV node has a built-in backup mechanism that blocks most of these impulses. It won't let them through, the so-called gatekeeper of the heart. Despite this ability to block all these extra beats hitting it, still, in the absence of drugs, approximately 120 to 180 impulses can get through to the ventricles every minute, resulting in a very fast, irregular heart rhythm. Now, the body does not tolerate that too well, and frequently you'll feel symptoms. The most common, of course, is palpitations, fluttering, the heart racing. In association with that, because the heart is so fast and less efficient in pumping blood, you may feel extreme fatigue and weakness. easily getting short of breath with minimal activity. You may feel dizziness, even pass out. If you are exercising, your exercise tolerance will be reduced, and sometimes with rapid heart rates, you'll feel chest discomfort to sort of mimic coronary artery disease. Now, as I mentioned before, the causes of atrial fibrillation are numerous. They're as long as your arm. First and foremost is age. If you live long enough, you'll get atrial fibrillation. As I mentioned before, over the age of 80, about 15% of the population has or have been treated for atrial fibrillation. However, if you have other medical problems, your risk will be lowered. You may develop it at a younger age. For example, if you have known cardiac disease, such as past heart attacks or stents or blockages, your risk is lower. If your heart muscle is weak, congestive heart failure, the cardiomyopathy, or if you have valve problems, severe valve problems, that will lower your risk. If you develop inflammation in the skin around the heart, pericarditis, that will lower your risk. Another potential cause is that the sinus node becomes sick with age. By sick, I mean it doesn't produce enough heartbeats, and you get a very, very slow pulse, inappropriately slow. The atria doesn't like that, and it could degenerate into atrial fibrillation. People who are treated for hypertension, high blood pressure, also have a higher risk of atrial fibrillation ultimately in their life. In the blood, abnormalities can produce atrial fibrillation. Abnormal electrolytes, like low potassium, low salt, things that you might see with excessive diuretic use, can trigger atrial fibrillation. If your thyroid is overactive, you can develop atrial fibrillation. Pulmonary problems, very common associations with atrial fibrillation, such as COPD, or if you develop pneumonia, or if you throw a blood clot from another area in the body to the lungs. All these things are not tolerated well by the heart. The heart is stressed and strained in this, and the heart could degenerate into atrial fibrillation. People who have diabetes, or if they're obese and have a sedentary lifestyle, or if they have sleep apnea and they're not using their CPAP mask, all these conditions are associated with earlier premature atrial fibrillation. If you develop a severe infection with sepsis, it's very common. We see in the hospital patients, especially elderly patients, admitted with infections develop atrial fibrillation in the hospital. Extreme stress can do it, probably due to the high circulating catecholamine or adrenaline. In fact, in my medical school class, in my freshman year, 150 students, within 2 days prior to the anatomy final, 3 of the 150 young students developed atrial fibrillation. Usually in those situations, the atrial fibrillation is self-limited and will go away, but it is a trigger. If you drink alcohol excessively, and especially if you binge, it is very common we will see an acute onset of rapid atrial fibrillation, and of course drug abuse will also lower your threshold. And finally, and very important, with the advent of the Human Genome Project, which I've mentioned in the past for other diseases, we've discovered genes that are associated with premature atrial fibrillation, even in the healthy young individual. And in fact, I have in my practice taken care of a family where the father and both of his sons have atrial fibrillation that began in their 20s. Now, probably the most feared complication of atrial fibrillation is the development of blood clots. Due to the relative stagnation of blood in the upper 2 chambers, it is not uncommon for the blood cells to stick together, more commonly in the left atrium, as we'll see in a minute with a future slide. If clots form in the left atrium and break loose, they drop into the left ventricle, they then get pumped out to the body. Not infrequently, they go straight up to the brain and cause a stroke, which is, again, the extreme fear of atrial fibrillation. The size of your stroke will vary depending on the size of the clot and the location in the brain where that happens. Now, you can develop blood clots that travel or embolize to other parts, too. If a big clot goes to a limb, such as a leg, that's also a potential emergency, because if that clot is not immediately removed, you can lose the leg and get an amputation. Clots can also go to other major organs, which obviously can cause organ failure and usually is associated with extreme pain in that region. Now, this is a picture of the heart, just the left side, left atrium, left ventricle. And as you can see, there's a spot in the heart there, a little outpouching of the left ventricle called the left atrium, called the left atrial appendage. In that area, blood tends to stagnate more and is a very common location for the source of emboli, of clots. So obviously, people in atrial fibrillation need anticoagulation or blood thinners. However, there are risks to blood thinning, as you well know. And the physician and patient must weigh these risks versus the potential benefit of starting this very serious drug to prevent clots. So systems have been developed to guide our judgment as to when to start blood thinning agents. The so-called stroke risk, or CHADS-VASc score, was created. Now, CHADS-VASc is an acronym composed of the letters that are associated with the most common and most significant risk factors that increase the risk of atrial fibrillation if you have them with you. The first one to see is congestive heart failure, or really any form of left ventricular dysfunction or weakness of the heart. You get 1 point for that. If you're treated for hypertension, high blood pressure, you get another point. If your age is 75 or above, you get 2 points, because that's a significant risk. If you're diabetic, you get a point. If you've already had a clot, a stroke, or prior TIA, which is a mini stroke, or an embolism anywhere in the body, obviously your risk of having another one is very high. If your blood is not thin, you get 2 points for that. Any vascular disease, like peripheral arterial disease, your legs, a myocardial infarction, arterial disease in the heart, plaque in the aorta, all of that is associated with a higher chance of getting blood clots with atrial fibrillation. If your age is not 75, but between 65 and 74, in other words, above 65, you actually get a point for that, which is why age 75 gets 2 points, because you get a point for this and one more for being above 75. And finally, it's been shown that women have a slightly higher risk of getting blood clots if they have these other risk factors over men. Now, what is the risk of a stroke based on this particular risk score? Well, if you have absolutely no risk factors and you're in atrial fibrillation, the risk of getting a stroke in 1 year is under 2%, relatively low. But you can see that as you add risk factors, that risk goes up and up and up. There's a total maximum number of 9, but anything 6 or greater, as you can see, gives almost a 20% chance of getting a stroke every year, which is extremely high. So all of this, again, must be weighed against the risks of blood thinners, but the current recommendations are that if your score is 0, you probably can get away with just an aspirin, which is a weak blood thinner. However, if you have a score of 1 or greater, just 1 or greater, it is recommended, if you have no other bleeding risks, to be anticoagulated. Now, in women, that's slightly different. Because women represents 1 point, if they only have that 1 point, have no other risk factors, we tend to not anticoagulate them. Otherwise, we'd be anticoagulating women in their 20s for the rest of their life just because they had a bout of atrial fibrillation. So for women, we'd like to have one of the other risks added to it before we will consider full-dose blood thinning. So we have to weigh the blood thinners against the risk of stroke. So what are the increased risks of actual anticoagulation that may allow us to, or basically make us change our mind and decrease or remove anticoagulation in lieu of just aspirin therapy? One, of course, is advancing age. If you're 97 years old and you have atrial fibrillation, there's obviously a higher risk of bleeding in the body. Unfortunately, age increases your risk not only of atrial fibrillation, but also spontaneous bleeding. And of course, there's the fall risk. If you have frequent falls, balance problems, there's a chance you may hit your head. You wouldn't want to be on a blood thinner for that. And the risk of very serious life-threatening bleeding outweighs the risk of stroke. If you have a history of recurrent bleeding on blood thinners, in other words, you've been on them, but you keep having major bleeds, you require transfusions, and may come a time where you just say, time to stop blood thinners. If you've had recent major surgery, you might want to wait till that's healed, again, before you start blood thinners. If you've ever had a bleed in the brain for any reason that was spontaneous, obviously, if you're going to add a blood thinner in the future, that risk goes up, and a bleed in the brain is extremely serious and life-threatening. If you have underlying advanced kidney disease or liver disease, those two conditions alone increase your risk of bleeding in the absence of anticoagulation. So adding it to these patients may be fraught with higher risk, and you would want to reconsider. If you have a markedly elevated blood pressure, such as 180 over 120, there's a slightly higher risk of intracranial hemorrhage, and you may want to get that blood pressure under better control before you consider these dangerous drugs. And alcohol. If you can't stop alcohol and you're an alcoholic, that too will increase your risk for a multitude of reasons: liver problems, increased falls, non-compliance with your medications. So let's turn our attention now to the treatment of atrial fibrillation outside of blood thinning. What do we do for the actual rhythm? Well, in recent years, there's been numerous debates as to whether treatment should be directed to just controlling the rapid rate associated with atrial fibrillation, which results in symptoms, of which we have medications listed there that can do that, versus should we just restore normal rhythm, just get them back to normal, and hopefully, in some cases, be able to remove blood thinning. Rhythm control sounds nice, but the drugs that are used to maintain rhythm control are definitely higher risk drugs that are associated with, in some cases, unacceptable side effects. Cardioversion is a treatment where one is brought into the hospital, sedated, they receive a little shock to the chest to bring them back to normal. It is reasonable in the first new onset atrial fibrillation in a patient to try to convert them back to normal with a little shock, because that is a relatively low-risk procedure. Well, that brings me now to atrial fib ablation, which I'm sure many of you have heard of or maybe don't know what exactly it is. Well, atrial fibrillation ablation is an invasive procedure. It doesn't come without risk, so you really have to pick and choose who you would want to do this to. The indications now for ablation include symptomatic fibrillation patients despite all these medications. You control the heart rate, things look like they're back to normal, but they're still extremely fatigued, tired, short of breath, palpitations, and their quality of life is poor. It is reasonable now to try to control, reduce the incidence of atrial fibrillation with a procedure whereby you actually place a catheter through the groin up into the heart. You locate the spots, usually in the left atrium, that we have found to be associated with the initiation of atrial fibrillation. You actually make little burn marks right around that area, usually with radiofrequency or cryoablation. There are two types of ablation. You burn that area, you literally burn that area, and reduce the chance that if fibrillation occurs around there, it won't be able to exit through the scars and be able to control it. Studies have suggested that atrial fibrillation ablation can reduce future cardiovascular mortality, and atrial fibrillation is being performed with increasing frequency now from year to year. The success rate for atrial fibrillation is about 70%, and nearly half of them will need a second procedure, as the atrial fibrillation may come back and they may need to be, quote-unquote, burned again. The success rate, however, is very dependent on the duration of atrial fibrillation and also the size of that chamber. If you've been in atrial fibrillation for 5 years, the likelihood that ablation will work will be much less. If that left atrium gets dilated or stretched out, the likelihood is less. As I mentioned, there is risk. The risk is low, but it is real, and so you will want to weigh risk versus benefit when considering atrial fibrillation in the management. Now, I mentioned that the blood clots that form in the heart usually are located in this little outpouching area in the left atrium called the left atrial appendage. There have been devices now that have been created that, again, it's an invasive procedure. You go up with a little catheter, and you stick a little device, which is called the Watchmans Device, shaped like a little parachute. You can see it there. It's actually shoved into that little pouch, and it prevents the blood from entering there and getting stagnated. And studies have shown that this particular procedure can significantly reduce the incidence of stroke and potentially allow for the removal of blood thinners. Usually 30 to 45 days after it's put in, you can stop the blood thinner. Well, this has just been a quick general overview for atrial fibrillation in the short time we have in a very otherwise complex subject. But in summary, I just want to say again, atrial fibrillation is a common problem. It increases with age and the risk factors outlined earlier. The atrial fibrillation can affect your quality of life, increase your risk of stroke, and it actually may shorten your lifespan, giving us incentive in some cases to get you back to a normal rhythm. The treatments outlined here have all been showed to improve future outcomes, but must be individualized and weighed against the risks. In any case, that brings me to a close on this short overview of atrial fibrillation. I hope this has made you at least more familiar with a very common problem, and I look forward to seeing you back here for future lectures. Thank you very much.